This is a Hope 1032 podcast.
Welcome to She Wasn't Born Yesterday, the pod that fearlessly chats about all things affecting us ladies who are 40 plus fabulous.
Well, and the guys that want to know what we think.
Well, them too. I'm Janet Evans, advertising creative.
And I'm Jenny Woodhouse, semi-retired social worker.
In other words, you're busier than ever. We're J&J and we're super thrilled you're with us, or she wasn't born yesterday. At around 3:30pm on Saturday, the 13th of April 2024, a 40-year-old guy called Joel Couchy entered Bondi Junction, Westfield, armed with a 30-centimetre knife, and within only around 6 minutes, he'd stabbed 6 people to death, he'd injured 10 others, including a 9-month-old baby, and was then shot and killed by Police Inspector Amy Scott, who responded to the emergency. And so this changed a lot of people's lives in a very short space of time. And I think it actually impacted all of us pretty much because it was such a dramatic and unprecedented event.
In such an ordinary space.
Yes, exactly. And I don't know about you, but I remember what I was doing that day when I first heard about it. Yeah, what were you doing?
I was at home and I suddenly became aware of all the helicopters overhead because I live just in walking distance from Westfield. So, yeah.
Right.
Yeah.
Yeah, right. We were driving back from a wedding and it had been a beautiful day and then we're suddenly hearing about, there's some police situation and all of that sort of thing. So earlier this year, there was an inquest into the killings and it heard hours of evidence from dozens of witnesses to try and understand how this guy with a long, long history of mental illness was able to just walk into a popular shopping centre on a busy Saturday afternoon and do what he did. So today we are incredibly lucky to have as our guest the 40-plus very fabulous Dr. Terry Lim, psychiatrist and director of the Mindsight Clinic, to help us all understand a little bit more about this guy's condition at the time and actually hear his expert opinion on whether it is possible to prevent something like this happening again. And if it is, then how? Dr. Terry, welcome back to She Wasn't Born Yesterday.
Thank you, Janet and Jenny, for having me back. It was a lot of fun last time, so looking forward to it.
I bet you are.
Just a light topic today.
A light,
that's
fun
right.
time.
So, as a psychiatrist, you treat lots of different mental health conditions, including psychosis, which we've heard that the perpetrator was suffering from at the time. So first up, what is psychosis and is there more than one type?
Yeah, so psychosis is not actually an illness. It's not actually a diagnosis. It's what we call in the medical world a syndrome. So a syndrome is a technical term for a group of symptoms that come together. And when these symptoms come together, we call it a psychosis. When we define any kind of psychiatric condition or illness, there's really 3 parts to any diagnosis. One is the clinical features, the symptoms that someone presents with. The second is whether there's a lot of functional impairment or distress associated with those symptoms. And if it happens over a significant period of time as well. And those time sort of frames are different for different conditions. Actually, psychosis is not that uncommon in the community, but it usually doesn't come to treatment because it doesn't really meet one of those criteria. Some people might have psychotic episodes that don't particularly affect their functioning. It don't last very long, maybe, a few minutes or a few hours, that kind of thing. And we never really kind of hear about it. So it's important to kind of understand that when we as psychiatrists medicalize something or diagnose something, it's because the person really needs help for that. And that's kind of the key thing there. Psychosis, in terms of symptoms, there's different groups. There's what we call hallucinations, which are disturbances of perception and our senses, delusions, which are disturbances of thought, and behavioral problems as well. So disorganization, social withdrawal, that kind of thing. They're the sort of symptoms that we associate with this thing called psychosis.
Wow. So you say that some of us could actually have psychotic episodes, but they're not noticeable by other people or they don't really impair us. Is that right?
That's right. Drug use is pretty common in the community. People might have a bit of an episode, they might have a hallucinogen at a party. They'd have what, for all intents and purposes, looks like a brief psychotic episode. They wake up the next morning and they're fine. No one's the wiser. Nothing's really impacted them too much in that one episode. And so that wouldn't really come to our attention. Is it a psychotic symptom? Yep. But we wouldn't necessarily treat it as an illness in that setting.
Yeah.
At what point would you actually treat something as an illness, or is it the separate parts that make up psychosis that are the illness?
Yeah, so I think once it starts to impair people's functioning or cause a lot of distress, I think that's when we start to take it seriously. And when you think about functioning, that could be in all domains. So how people relate to each other and other people, how they manage work, study, that kind of thing. The most common age group that psychosis happens in is younger people. And these are typically people at the prime of their life, and that's why psychosis can be so debilitating. Because it affects people at the time when they're meant to be really launching into the world. And so that's when we try and help people. So early intervention is the most effective type of intervention that we can have. It really determines the course of people's lives, and that's really when we'd step in.
Yeah, or it would have to be identified by someone, wouldn't it? Because
That's right.
presumably they wouldn't self-present to you, interpreting their own symptoms. It would have to be someone observing them and going, I don't think that's quite right. Is that right?
Yeah, actually, it's a bit of a mix. I mean, a lot of people do present in distress because they think that something's happening to them. They wouldn't associate it as psychosis. They'd kind of think it's something really happening. And so they'd come for treatment for that particular problem. After some investigation, for example, we might figure out that there aren't insects inside their body kind of thing. And so, we might sort of say this is a mental illness.
Okay. And are these kind of symptoms, I guess, for want of a better word, are they genetic mostly, or there's not much research into it? Where does that sit?
So when we talk about psychosis as a syndrome, there's so many causes of that. So it's a bit like saying temperature or inflammation. It's really the end of the road for a series of processes that might be going on. So some of those processes, we may not know what the exact cause is, like in schizophrenia. But for some people's psychosis, it could be secondary to a medical illness. An organic brain condition like dementia or delirium can cause that. But the most common cause of psychosis really is probably substance use. A lot of substances are associated with psychotic type features. Really common substances like cannabis, even alcohol can be related to kind of psychosis. So it really depends on what the underlying cause is. But there is a genetic predisposition sometimes to whether someone develops psychosis.
Yeah.
Often.
I mean, this particular guy, we understand now, had been in the mental health system for some time, like decades, and he was diagnosed with schizophrenia when he was a teenager and also diagnosed with obsessive compulsive disorder. But do these conditions necessarily cause or contribute to psychosis?
Yeah, so as I said, psychosis is a really broad group of, conditions. Schizophrenia is a condition where the core feature of that condition is psychosis, and it doesn't really have a known cause, although, as I said, genetic predisposition is really important. So there's a higher sort of genetic risk in families with psychosis or schizophrenia. But there also often needs to be some kind of secondary environmental stress. So often, as I said, drugs are often a really common contributor to that. Stress. It really depends on how that person's predisposed, as it were. And obsessive compulsive disorder is not associated with psychosis usually. It's an anxiety disorder, although OCD and schizophrenia sometimes go together. OCD can be a complication of treatment for schizophrenia. Some of the medications that we use can trigger OCD type kind of presentations as well as side effects. So it's a really complex, relationship between the two.
Goodness me, it is. You mentioned just a few minutes ago about a psychotic episode. Is it the case that somebody might suffer from one psychotic episode and it never happen again? Or would you expect that it would be something they'd have to look out for?
That's probably the most common experience that most people would probably have of a psychotic episode, shall we say, is that it happens once, it doesn't happen again. It's often associated with stress or, as I said, substance use. People are like, oh, I don't want that again, so I'm not going to touch that again,
Absolutely.
And that's not uncommon.
Right.
But certainly there are conditions like schizophrenia where it's a risk, lifelong risk.
Right.
And so if you diagnose someone as having psychosis, how would you treat them?
So again, it depends on the underlying cause. If it's kind of drug-related or stress-related, we'll obviously try and, prevent that happening again. So it's about looking at the conditions in which the person lives and how can we help them to be a healthier individual. I think that's really the goal of any kind of medical treatment. We look at everything. It's a really holistic approach that we take to people with psychosis. It's sleep, it's appetite, it's diet, it's exercise and stress. But a significant contributing factor to why people become unwell is their environment, their family environment in particular. There's often a lot of family stress, a lot of family conflict. And so these high stress family environments often contribute to people getting unwell again. In terms of schizophrenia, it's a really tragic condition, schizophrenia, because as I said, it usually comes on as people are reaching the prime of their life. And the evidence is that early intervention is the best. And the type of intervention that works the best is a multidisciplinary, service-based approach. And that's the challenge with cases like Bondi and other cases involving chronic psychosis and schizophrenia, is that often the services and the teams that are supposed to be helping patients and their families are often insufficient or they fail. And that's when we talk about people slipping through the cracks.
Yeah, it's a really interesting expression, that, because it was used a lot about this particular
Couch,
because I think at the time that he did the killings, he was actually homeless. I think he was living in a storage unit, actually, and he'd moved right away from his family, from his previous psychiatrist. And so it seems he was very much isolated from all of the support mechanisms that he had around him originally. And that must be something very difficult. Obviously, you can't control what's going to happen to someone, even if you are treating them and they make a decision, I'm going to go into state and I'm not going to take my medication. Is there anything you can do about that or not?
Yeah, that's the $1 million question, I think. And, I think the challenge with trying to learn from experiences like these or events like this is often the answers are not answers that we don't know. It's not that we don't know what the fixes are. It's how to implement them.
Yeah.
And whether the government of the day has the will to action, a lot of the things. And this is not the first inquest, I think, that has been made into a mental health related tragedy. It is difficult. We live in a country that has a lot of states, and each state is kind of its own jurisdiction. And so that, I think, creates a lot of problems in terms of the disjointedness of various systems and policies and whatnot. Yeah, we also don't want to live in a society where we want to control everybody as well. There's that really fine balance between respecting people's autonomy and freedom and also protecting the public as well, and also helping that person to get the care that they need but often don't want. And they're really tricky ethical dilemmas that psychiatrists face every day.
Joel's mum was wanting to speak up and say, I'm worried about my son. At what point should we speak up about, what are we looking for in order to be concerned enough to try and impose some help on somebody?
Yeah, that's a really great question. Again, really difficult. I think it's really important that health systems and health services listen to families, because families know their loved ones the best. And I don't think any mum or any parent really wants to alert authorities about their kids.
Yeah, true.
And I think if they're doing that, then we really need to take that seriously. In terms of how the average person can look out for people who are unwell, I think it's about relationship. I think if we're in relationship with people, we'll get to know them, and we'll get to know their warning signs when they're not doing so well. The challenge, I think, for our society is how do we maintain those close relationships and connections? There's a lot of society breakdown of the institutions that we used to take for granted. Often governments and schools and other institutions, authorities are expected to kind of try and fill that gap. It's really hard. We have blunt instruments, shall we say, and often those blunt instruments are really not enough.
So at the moment, there's all sorts of different jurisdictions in different states, and the police have different powers in different states, and the mental health system also works differently, and they're not all talking to each other. Is that right?
Yeah, that's pretty accurate, actually. I think everybody seems to silo their information away. Part of that is respecting people's privacy, and so there's really strict rules around what we can share, what we can access. Certainly continuity of care is a great reason for share information. But it's kind of comes down to, I think, also what kind of society you want to live in as well. Do we want to monitor everybody? But also we do need to look at how we can share systems better. There was an electronic medical record, I think, that came out, and that caused a lot of controversy. Do I want my medical record shared amongst everybody? But, that could be the difference between life and death. So I think it's something that we in the free West are still trying to come to grips with.
Yeah. Well, I guess particularly when it comes to psychiatric conditions, that, you know, are deeply impacting someone. And it obviously was impacting this guy and his immediate family and those people around him. So, I mean, would a kind of overarching national kind of register have helped in this situation, do you think?
From what I understand, the treating psychiatrist had enough information to treat Jo. I mean, I can't comment on the decisions that she made at the time, and I really do feel for her. You know, she must be feeling terrible.
Absolutely.
And to be put under pressure like that in an inquest is really hard. So, you know, so I think unless we're actually there in the moment, it's really hard to comment on the decisions that she made. But it sounds like there was enough information to be concerned about his mental state. Often, though, that concern doesn't necessarily translate to what kind of action should we take. To take someone's liberty away is a big deal, you know, and I think in the West we take that someone's right to liberty pretty seriously, and so we should. So sometimes, again, as psychiatrists, we're skirting that really fine line between, you know, when do I deprive someone of their liberty, force them to go in hospital? Often we get it right. Most of the time I think we get it right. Once in a while, maybe we don't, and it's just
How
one of
is
those
it that
things.
you could force someone to go into hospital? How does that actually work?
Yeah, so we have this thing called the Mental Health Act, and there's forms of it pretty much in most countries. The tricky thing is that in the past, it's been used as a tool of political oppression in certain countries, and it's a very sensitive tool, and that's all it is. It's a tool to force people to get help if they don't have the capacity or the insight to make decisions for themselves. And also, if they're at risk to themselves or other people. So they're the two criteria that we use. Do they have capacity to make decisions for themselves? And are they at risk to themselves or other people? So they need to fulfill those two criteria. In New South Wales, we have safeguards around wrongful, I guess, you know, detainment of people. So we have independent magistrates that review the decisions made by doctors. So it becomes a legal process. And patients actually have a legal representative at these hearings, and that's mandatory. Through legal aid. So it's quite a robust legal system. Having worked with that for, you know, over 10 years, you know, I can tell you it's quite robust. And I think we've got pretty good safeguards around keeping people wrongfully. The problem I think we face is when should we bring people in? And I think that's the thing that most of us really struggle with. At what point do we say, no, you're a real risk and we're willing to you know, treat you against your will in somewhere you don't want to be?
Very tricky.
Yeah. So if you've got, you know, I walk out my front door at 10 o'clock at night and see a man who's acting very strangely on the street.
That would be most nights around Randwick, I think.
Yeah, I wasn't going to say that. But just saying, on one random night this happened, and I call the police, is it then up to the police to make that decision about what they do? Whose decision is it to start with?
Yeah, that's a great question. So, I mean, again, at the moment, we really have a 000 number. 000 number goes to an operator, and the operator has to determine whether this is a police emergency, a medical emergency, and often a big crack that people with mental illness face is they kind of fall in between those two domains.
Yeah, right.
It is a health issue, but it's also a public safety issue sometimes. And health services don't really see their role as protecting the public, and police aren't really equipped to deal with health issues. So often the person's caught in between, and 9 times out of 10, if not more, it'll be the police that turn up first, which often has a lot of tragic consequences.
Oh, awful, especially if it's happening within your family to your child and want to, you know, who wants to call the police to their child?
Exactly.
And have that happen.
But also, so what would the police do then if they kind of assess this person as being a danger to themselves or the community? Would they just whack them in jail?
Well, what happens is that, so if the police determine that someone is likely to have a mental health issue, they have the power as well to enact a detainment to a hospital if they think that that's more appropriate rather than a lockup, for example. So they have that discretion, and a large volume of work for the psychiatric trainee on call is dealing with police presentations of people who are intoxicated or who have some kind of mental health disturbance of some sort. So that's really challenging, as you can imagine. And emergency departments are not equipped really to deal with that very well.
Yeah.
And also it's very traumatic for patients and their families when the police are the first ones to turn up when someone's obviously psychotic. And unfortunately, that's a system we're kind of stuck with at the moment. And I think I could probably speak for my profession in saying that's a shared frustration that out of all the years that we've been doing this, it's still the system. The police turn up, no one else is there. And no one's really bothered to really look at that. It causes a lot of trauma and a lot of a lot of distress.
So do you feel that both an ambulance and the police should turn up to situations like that? Would that help to alleviate that somewhat?
Sometimes an ambulance will turn up as well. Sometimes an ambulance will be the first on scene, and if they feel unsafe, they might call the police. It's kind of a toss of the coin as to who turns up first.
Yeah, right.
Often it's to do with age as well, and certainly if it's an older person, an ambulance might turn up first. So I think the ideal scenario would be if a mental health trained worker could turn up, because often, again, ambulance workers aren't that well trained in dealing with mental health crises as well. Someone who's trained to recognise the syndrome that's going on would be really helpful. So some jurisdictions have that. Some services have started to do that, but it's not really enough.
So how have they done that? Which jurisdictions have done it and how have they done it?
I know it happens in, I think Victoria have some services where police will attend with a mental health worker, a case manager. Often they're trained psychologists or the social workers or people with some kind of health background who have a specialist training in mental health services. I think in New Zealand they've got similar services. Unfortunately, I don't think there's enough resources to do this 24 hours a day, and I think that's the problem. It happens at sort of 3 a.m.
Exactly.
The emergency department's full. It's a full moon. The police are out and about.
Yep.
Everybody's stuck. So I think that's where the challenge lies. Yeah.
Is that an actual thing, the full moon bit?
And windy. Apparently, if it's really windy, people go crazy as well.
Well, I'm not sure there's a lot of data around that.
Anecdotally,
or the
Terry.
word crazy.
Anecdotally. Well,
Sorry.
certainly there's a seasonal element to mental health presentations.
Really? Okay.
Spring is there's a bit of a spike in certain presentations around spring. Certainly in winter, especially in prolonged winter, there's more episodes of depression and that kind of thing. Fortunately, in sunny Australia, we have a lot of sunlight, so we're usually protected from that.
That makes your job easier, right?
It does,
right.
absolutely.
That's
yeah.
right. So coming back to Joel Couchy, is this what happened? Can you stand back and look at the entire case and just see how he slipped between the police response, the ambulance response? He's slipped between everyone's response. As Janet was saying earlier, he took himself to another state and he's now
off his
medication and nobody's watching him, etc. My first question, I guess, is as you look at the case, is that what's happened here?
That his psychosis has been...
That his psychosis has not been picked up by anybody in particular.
And it's
he's getting worse.
Built and built.
Yeah.
Yeah, well, I think one thing we can say is that his psychosis went untreated for a really long time. And we know that the longer someone's psychosis goes untreated, I guess, the more intense it becomes, the higher the risk is that a behavioural disturbance will lead to some kind of harm, usually to the person. It's rarer for there to be a significant harm to other people. And I think that's another point I really want to draw everyone's attention to is whilst psychosis is associated with a higher risk of violence to other people, the absolute risk is still pretty low. The vast majority of people with psychosis really don't pose any threat to anybody else. As I said, it's a really common experience. And even amongst schizophrenic patients, schizophrenia is a pretty rare condition, probably about 1% of the population. Even amongst the patients with schizophrenia, the risk of violence to other people is still pretty low. And so I don't think this is necessarily about people with schizophrenia or psychosis. I think this is about a system or the lack of systems that were able to pick up someone like Joe, who was really unwell for a really long time. And if we talk about the thing that I noticed the most about the whole case was how disjointed everything was. There was a private practice psychiatrist. He'd been in the public sector for a long time. He was homeless, so there's social services that were kind of may or may not have been able to help. And then we talk about law enforcement. So there's a real disjointedness about the whole thing. And that really, to me, is the take-home message. How can we coordinate services better? How can services talk to each other better? How can families also, it's not inconceivable that one clinician might miss something, but is there a safety net? And I think that's the other thing that we could talk about as well. Private practice is pretty challenging. So you see patient after patient after patient, and often, you're kind of time poor and under pressure. It's not really an excuse for kind of bad practice. And not that I'm saying that there's any bad practice here, but I think everybody needs to think about what are some of the safety nets that we can put in place if a patient's mother isn't happy about the response. Who else can they turn to? And maybe the family didn't know who else they could get help from. apart from their psychiatrist.
Yeah, I reckon that would have been a big issue because I suspect, I don't know, but I suspect he kind of just took off and they might not even have known where he was. So how are you going to sort of follow someone up or support them if you don't even know where they are or what they're doing or what medication they may or may not be taking? It's not like you can really monitor them, is it?
Well, the police are equipped to track people down.
Okay.
And so I'm not sure where the police kind of fit into the whole case necessarily, or whether they were alerted. I mean, they can only act on information they receive. But certainly from my dealings with the police, I do take reports of people who may be at risk to themselves or other people pretty seriously in terms of trying to find them. If he's in a shipping container somewhere, it's virtually impossible. And that's, again, a not uncommon scenario where someone who has active psychosis still retains a lot of their planning abilities, their ability to be mobile, access money from places, be resourceful. So it's really tricky. And again, I make the point that this is a really, really rare occurrence, which is why it's really hit the media. If this happened every day, we wouldn't be batting an eyelid. But the fact that it's gained so much attention, brought about an inquest, I think it shows that there's a lot of people who do get the help they need and who do have good outcomes. So, I think it's important to acknowledge that too.
Yeah,
but
I
it
agree,
has,
actually.
that's true. That is true. But it has highlighted that there are still cracks.
Absolutely, yeah.
Have you got thoughts about how to stopgap those cracks?
Well, at the same time as this was going on, the inquest is going on, the government was having a fight with the Industrial Relations Commissions with the entire public psychiatric workforce.
Yeah, that's
right.
right.
So I think
that's right.
I think the problems run pretty deep. So, there's been quite a few reports that have been put out in the last 12 months or so around the psychiatric workforce. And it's pretty worrying reading. The College of Psychiatrists, if anyone wants to navigate to their website, they've got a couple of reports that they've commissioned. One of the reports is, I think, New South Wales mental health system under the brink, something like that. It's just pretty dire reading. I mean, it just talks about how under-resourced our mental health system is, how inaccessible it is for a lot of people, how disjointed it is. And so I think it's up to all of us as, members of the public even to understand the problems so we can lobby for change, so we can write to ministers, we can tell our stories. If someone's been affected by a gap in the system, they need to speak up about it.
Yeah.
There's a strong consumer movement as well in the mental health space. Consumer advocates are often people with lived experience who gather information and data. I think we need to listen to them as well.
Yeah. Is there any way if someone presents to you and they are psychotic and have this group of symptoms, is there any way that you can tell whether they're going to be violent to other people or themselves or not?
Yeah, that's a great question, Janet. So as I said before, psychosis does confer in itself a 4 or 5 times increased risk of violence to other people. Again, it's important to acknowledge that 4 to 5 times increased risk is still a low absolute overall risk. So that in itself, but there are also things that mitigate that risk as well, so bring it down. And that include things like good family structures and good family support, whether that person has what we call insight and what their baseline cognitive ability is. So if they're kind of fairly high functioning before they've become psychotic, that's often a good prognosis. The sort of things that we are worried about are active substance use. I mean, that's number 1, 2, 3, 4, and 5, really. If someone's using stuff, that's when we're really worried. If someone has a previous criminal history, that's also a concern. We also look at sometimes the content of what they're thinking. So if someone has really strong beliefs that people are out to get them, and those people are specific individuals, we may obviously take that a bit more seriously. And so that's all forms part of the assessment. Most of the people with psychosis I see in private practice have pretty good family supports, and I can treat them in a collaborative manner. I can't remember the last time I actually kind of forced someone into hospital, in private practice, but obviously in public practice, it's a daily occurrence where we're dealing with the Mental Health Act, and so it's a really tough space to work in.
What sort of impact does it have on you that this whole area you're working in produces a dire report, basically?
Yeah, I think this goes to the whole dispute that's going on at the moment in the public sector. I think the government sort of tried to make it money, and I think remuneration is one aspect, especially if the government's also spending a lot of money on locums instead of regular staff. That's kind of tough to take, I think.
Yeah.
But really what you're talking about, I think, is something called moral injury. So moral injury is the concept where one is forced to work and provide services against their values. So it's really, really hard to force someone into hospital and force them to have a needle, for example, and to see them held down by security guards so that they can give them that needle. Now, we by and large are able to justify that because of the sort of ethical dilemma that we're in.
Mm-hmm.
But if it happens in a way that's not justifiable, then that can really cause a lot of this moral injury that we're talking about.
Yeah.
And that happens when hospitals are short-staffed, when we're using these tactics really to control behaviour and to keep staff safe rather than actually treating patients. When patients are talking about how traumatic it is to deal with the mental health sector, and then as a psychiatrist, you're a key part of that. All these things really chip away at your sense of wellness and who you want to be as a person. So it really is quite a confronting space. And I think that goes to the heart of the industrial action by the psychiatrists.
Absolutely. So again, I guess let's encourage folks who have a story to tell where someone they know has fallen through the cracks or is, it hasn't worked out for them, to speak up about it would be helpful.
And I wonder too, like if we know a family who is experiencing this with their son, daughter, that sort of thing, how can we best support people in this situation?
So if it's your loved one, I think it's really important to understand the mental health system, what services are available for your loved one, and really engage with those services early. As I said before, there's the private health sector and there's the public health sector, and they both have their place. One of the difficulties of engaging with the public health sector is that it's often crisis-driven and it's emergency-driven, which can lead to really traumatic experiences, really heavy-handed treatment. So you really want to prevent it getting to that stage. Sometimes it's hard to if people don't want to get help, and by definition, anything outside of the Mental Health Act is voluntary. And all we can do is present the options to the person who needs help and really encourage them to do that. But it's really challenging. And I think we know that the outcomes are better if people are in higher socioeconomic areas, which is sad. And so I think part of the long-term solution, I think, as well is thinking about how society as a whole functions in terms of the health inequalities, the income inequalities that we have, housing issues, domestic violence. So those are all kind of broader systemic things that I think the government needs to address. But in terms of how we can support each other, I think, we need to strengthen social bonds and social relationships. I think that's really important.
I think that'll be a great help for all sorts of issues.
Yeah, that's right.
Psychosis. Is there research around, is it more males that suffer from psychosis or females? Is there anything that supports that?
Yeah, there is a slight male, bias in terms of schizophrenia in particular, which is the chronic psychosis that doesn't often have an obvious cause. Although, as I said, it can be precipitated by drug use. Certainly there are more males in the forensic sort of system as well. So males are more likely to perpetrate sort of significant acts while they're psychotic than females. Females tend to present a bit different in terms of how they have psychosis and the conditions that they, that sort of are associated with psychosis. So, for example, postpartum psychosis, they're more likely to be associated with a mood disorder. And also trauma is quite a big driver of psychosis as well, and psychotic type phenomena. So again, trauma is a group of conditions that are really misunderstood and undertreated, I think, in the community. And again, it's really ubiquitous in people with psychosis is some kind of history of trauma.
Thank you.
So just to finish up, one of the victims' mums told the inquest, she said, "It seems to me that my daughter and 5 others died by the cumulative failures of numbers of people within a whole series of fallible systems." And I think we'd probably all agree with that. But Dr. Terry, if there's a summary of what you think could help actually improve this situation and, if not prevent, at least make everyone a bit more aware of the dangers, what would that summary be?
Look, in a tragedy like this, there are no winners.
Yes.
The psychiatrist that was involved, the families of the victims, as well as Joe, his parents, there's just a lot of suffering and sadness all around. And I think if we as a society have an inquest, put it aside and don't really learn from it, then I think that's the real tragedy of it all.
Yes.
What can we learn from it? I think a bipartisan approach politically is really what's needed to fix these problems. It's like a political football that goes from one government to the next. Doesn't seem to matter who's in government. Mental health funding is really bad. It's historically bad. We had an Australian of the Year, Patrick McGorry, a few years ago, and that was great because with that, he brought a lot of awareness to mental health treatment. And I think awareness is growing. And thanks, guys, again for your podcast in drawing attention to these issues, because mental health issues touch everybody.
Yeah, as we know.
I think these reports that are brought out by the college, even the Australian government put out a report that showed how short-staffed we are. We just need more action. Less reports, more action, I think, because we know what the reports are going to say.
Yeah.
That sounds like a really good summary of today's episode. Less reports, more action.
More money.
More money would be good too.
Yeah.
Well, Dr. Terry, thank you so much for your time today. We really appreciate it. And it really actually has sort of opened my eyes too as to, your profession and the kinds of decisions that you guys have to make, which can be so pivotal and there's so much responsibility. That's why I think I'll stick to advertising. But we're so, so glad that there are people like you out there really caring holistically for people's mental health and treating them appropriately.
Absolutely. Thank you so much. We very much appreciate it.
Well, thanks, guys. I've had a great time and thanks for the opportunity.
Janet, we love hearing from people, don't we?
Even more than I love you.
So to leave us a message, go to hope1032.com.au, She Wasn't Born Yesterday podcast, and hit us up on the little Get in Touch box at the bottom of the page.
Doing that right now.
And we'll see you next time.
See ya.
Hope 1032. Thanks for listening.